Linda Powell, and I'm moderating the session today. So welcome everyone for today's webinar, which is entitled Legislative Impact in the Context of Health System Transformation in Nova Scotia. I will introduce our two speakers, Dr. Kristina Krmpotic and Alain Landry, momentarily. So from foggy and snowy southern Alberta, and we believe that's the case as well in Nova Scotia from the news, I will provide the land acknowledgement for the University of Alberta, the host of this webinar. We acknowledge that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. Thank you to Paladin, Astellas, and AstraZeneca again for their support of the ATI seminar series. So very pleased to present our two speakers today, who have been knee-deep in the organ and tissue donation system transformation in Nova Scotia. Alain Landry is originally from New Brunswick, where he obtained his health science diploma and Bachelor of Nursing. After receiving his critical care certificate, he spent most of his career within the critical care environment. He is currently the program manager for Legacy of Life and Critical Care Organ Donation, which is the organ donation program of Nova Scotia, and also has been a member of the steering committee for the LEADER program, Legislative Evaluation Assessment of Deceased Donation Reform Program. Dr. Kristina Krmpotic is a pediatric intensive care physician at IWK Health in Halifax, an associate professor in the Department of Critical Care at Dalhousie University. She is a donation physician for Legacy of Life provincial organ donation. She was co-lead for Activity 1, quantitative evaluation of the Health Canada funded LEADER program, and has an active program of research in the area of organ donation. So over to you, Alain and Kristina.
So Alain and I have no disclosures today. We are both within leadership roles at Legacy of Life, as Linda mentioned. So Alain and I are going to present to you today, hopefully help you understand the context of the legislative change in Nova Scotia, outline the key elements of our system reform, and share some of the historic and preliminary results of the system reform within Nova Scotia. Next slide, Alain. So my colleagues and I have been asked to give a number of talks over the past few years related to the interest in learning from Nova Scotia's experience in implementing deemed consent legislation. We are the first jurisdiction in North America to enact this legislation, and we've had a lot of media attention nationally and internationally about our experiences. Next slide. To understand the context for our legislative change in Nova Scotia, I think it's important to have a historic perspective. Between 2006 and 2016, you can see from the bar graph on the right that Nova Scotia had the highest performing deceased donation program in the country. Our annual deceased donation rates per million population were consistently above the national mean, ranging from 15 to 26 donors per million. But over time, donation rates in Nova Scotia stagnated in comparison to provinces like BC and Ontario, where governments invested in the maturation of their deceased donation programs. The Nova Scotia Liberal government became very invested in organ donation and was impressed by the deceased organ donation rates in countries with deemed consent legislation, countries like Spain, Croatia, who were really the highest performing in the world. And so they were very optimistic that implementation of deemed consent legislation would improve our deceased donation rates in Nova Scotia. However, many countries have demonstrated the importance of accompanying health system transformation in conjunction with these legislative changes. And this figure shows the increases in deceased donation rates in Spain over time. And although deemed consent legislation was enacted in 1979 in Spain, the significant increases in deceased donation activity weren't really observed until the establishment of the National Transplant Organization in 1989. And it was around that time that the Spanish government invested heavily in supporting the infrastructure that was actually required to create a culture of donation, with the pillar of the Spanish model being mass media campaigns. So, understanding the importance of all the key components of high-performing deceased donation systems, the Nova Scotia government committed, along with the legislative change, to the provision of frontline financial resources that would allow the growth of infrastructure, organizational oversight, more donation specialists, healthcare professional education, the ability to generate timely performance metrics for benchmarking, and public awareness campaigns.
So just to give everybody some background on how it actually happened and the timelines for legislation in Nova Scotia. So in 2018, 2019, we had the call to action where it was actually the government that engaged with us to wanted to pass legislation for deemed consent. So this was actually put on hold due to COVID and became into effect in 2021, January 18 of 2021. So the key elements we have, I know everybody talked about deemed consent, but there's other key elements within that legislation that are important for us, which is mandatory referral, direct contact between donor families and transplant recipient as well. So after, well, I would say pre-legislation and post-legislation, obviously there was some system transformation that needed to happen. So having the law, like Dr. B would say, is one thing, but to actually being able to reinforce the law, monitor the law, and be able to support, say, increase in volume donation, you do need to try to make sure the system can support it. So for us, we really focus on expansion of the team, and having an operational reform on how we actually operated pre-legislation. And we also knew we needed a system, like a donor management system, and having a plan for education and engagement. So in 2022, so this is, I'm going to say, post-COVID. We're still kind of at the end of the last wave of COVID. So our education engagement was really sidetracked as we were not able to travel to any ICUs. There was a lot of restriction and also really challenging to meet with different teams within critical care. So really our education really started to get traction in 2022. And we did see a positive correlation between our referral rate and our engagement. So this is when we actually saw our first increase in referral by 130%. So then after that, we went back to kind of do an assessment on what we need again. So now we have an increase of volume. We're trying to not have any missed donation opportunities, but how can we actually create this feedback loop to, one, tell people if they're missing any donation opportunity and kind of change the culture. So we established a new reporting process that Dr. Krmpotic will go over shortly. And how can we tailor approach at different sites that we're engaging with provincially. And last year, we were really looking at the impact. So 2023 was actually the first year that I would say, have a full year of data, because 2021, 2022, most of the team had been deployed to ICU for the COVID efforts. So the numbers were a little bit skewed by that. So 2023 will be our full year of data where we can actually measure the actual impact or currently impact that we have. So we look at our program metric and a performance indicator. So we kind of put everything in buckets on what we wanted to target as a system reform. So 4 key elements that we kind of divided into is education, clinical operation, IT solution, and the donation team. So we have a plan to expand the donation team. Clinical operation, we knew we had to look at how we were functioning currently and how this could look like. So projection on increase of volume of referral, it being able to support more organ recovery. So there was some projection. We already knew what we needed, and some were kind of learned as we went. For IT solution, we already knew we needed a donor management system as everything was paper-based in Nova Scotia. We wanted a reporting system, included a post-debt audit system that we will show you guys a bit later in the presentation, and also built a module for the family services system tagged with our donor management system. The education, so for us in Nova Scotia, I think it might be different from province to province, but in Nova Scotia, we do have the mandate of public education and healthcare professional. So we wanted to have a strategy on how to engage with different groups about this. So for the donation team, so this was the early plan pre-legislation. So in 2018, very slim, as you can see, 3.6 coordinator, FT is a full-time position, and we had a quality lead part-time and a medical director. So with the projection we were having with legislation, we made a plan on 2021 what we need. So double the coordinators. We wanted to build a donor physician across the province at every site. So we wanted to be able to have donation physician at 10 hospitals. Quality lead full-time. We wanted a database analyst, education support, family services, and IMIT support and project lead. So those were all added. And this was the 2021 assessment, has since changed as we learn, as we go, what are our needs and increase. This was based solely on projection that we had in 2021. So for the education, we focus on different aspects. Since we have a mandate for general public, we needed a strategy or a framework to say, what do we need? So internally, expanding the team creates a need. So if you have a team that's been in place for years, and then all of a sudden you're hiring new staff, you need to be able to onboard them to get to know some donation, to get some donation training, ongoing education, clinical workshop, developing some maintenance of core competency, and donation physician, which was also a new role. And then for healthcare providers, we knew we wanted to do education session and site visits across the province, develop all the education material that was needed, and how do we make it accessible for those teams. And the general public, which I think is always somewhat of a challenge, is how do you disseminate that information for everybody, for this to be available to everybody. So that was kind of our plan for education. And on the operational, clinical operations, so in Nova Scotia, it's also important to know that the coordinators does the entire donation process, so from the referral to organ recovery to post-transplant follow-up. So we had to review everything that we had in place, workflows, what material is needed and what needs to be developed. And also the family support program was all new, so we need to create that from scratch here in Nova Scotia. And the IMIT already mentioned is we had 3 systems we wanted to build in-house, just to be able to support the volume that we were expecting. So really, to have all of this, I think that the main goal is how do we create a feedback loop around the province. So that will meet a few needs. Is we want to develop a donation culture around the province. What do people need to know? And also, if they're missing donation opportunities, they need to know and how they can improve. So that was our main goal with all those components coming together, is what does people need to know from us? How can we support them? And then over time, we would be hopeful that we're seeing improvement. So that being said, I'm going to pass it again to Dr. Krmpotic, where she's going to talk about how we created those reports and this feedback loop around the province.
So as Alain mentioned, one of the top priorities within our program was to develop a system for donor audits, because we wanted to establish our baseline performance and be able to generate timely metrics and assess site-specific needs at each stage of the donation process. Prior to the time we developed this, just to give a sense of how rudimentary it was, we had a form that we would collect. We would get lists of patient in-hospital deaths 6 to 9 months after they occurred. The charts would be audited and go onto a paper-based form that would go into a filing cabinet. And anytime we wanted to take a look at any of our information, people were doing hand counts. So not exactly the best way to generate metrics for either improvements in benchmarking or to identify areas where we needed improvement or needed education based on our numbers. We wanted to be able to examine reasons for potential donor loss from the identification and referral through the next of kin approach, through consent, recovery, and declines by the transplant program. So the process started with an environmental scan just before Legacy of Life, at Legacy of Life, just before the LEADER consortium was formed. But we moved forward together with the LEADER program. Nova Scotia Health and Legacy of Life developed a platform for the searchable electronic database. And LEADER provided the support of 2 full-time research assistants to perform over 4,000 chart reviews spanning from 2017 to 2020. And the purpose of this was to generate some pre-implementation metrics to see where we were starting from, but also to sort of kickstart the platform that would become the DMS and pilot that, which Alain will show us in a few minutes. We did actually publish our PDA tool and some of the lessons we learned from those first 1,000 medical record reviews, which was 2020. And just to walk you through the process of how we developed this. So this was our timeline, and you can see it was a lengthy process. Since we were starting from scratch, we wanted a donor audit tool that captured the information that would be required to answer questions around quality, education, research, and then have an electronic database that would replace those crude paper-based audits that I told you about. So we had started the environmental scan just before the formation of LEADER. And we collected potential donor audit tools from ODPs around the country that were routinely performing jurisdictional potential donor audits. And then we pulled in key stakeholders from multiple domains, people with clinical research and education perspectives. And we kept all the fields that were relevant to any of those representatives. And we removed only those that were deemed unnecessary by everyone and added any new items that were suggested. On the clinical side at NSH, we worked with a senior systems analyst and we started building the data entry and management platform. And the research team worked on our SOP manual with the data dictionary. And then after about 9 months, the database finally went live and the chart auditors began reviewing charts with us continually addressing technical issues, workflow modification, and refinement of our fields. The 2020 chart review process was completed about 10 months later, and we had data on just over 1,000 patient deaths in ICUs, IMCUs, and emergency departments that were occurring in all Nova Scotia health hospitals. And the complete audit involved patients who died within 12 hours of discontinuation of invasive mechanical ventilation. And so we actually captured quite a broad group of people because we wanted to make sure that if we wanted to apply different filters, so looking at functional instead of total donor warm ischemic time, how do you define a missed referral retrospectively? We wanted a database that we could really explore questions about the what ifs. At that point, we did our interim analysis. We locked in what would be the Nova Scotia PDA tool for the remainder of the historic performance reviews from 2017 to 2019. And then it was used as the basis for finalizing our donor management system for prospective intake of referred patients. So what happened when we examined that 2020 data? So the first thing I'd like to point out is that we saw a dramatic improvement in Nova Scotia deceased donation rates in 2020, which was actually the year before enactment of deemed consent legislation and going on during the first year of COVID. During that time, there was a great deal of media attention and growth within our program with respect to organizational infrastructure and support for hospitals outside our tertiary academic hospitals in Halifax. And I think this really highlights the importance of the entire system transformation beyond the legislative change itself. In the paper that I just referenced, looking at each stage of the donation process in 2020, you'll note that for referred patients, which are down that center column, the referred patients who were deemed medically suitable for donation in real time, our next of kin approach rates were 100%, and our consent rates were above 70%, suggesting that those stages in the donation process were not necessarily the ones that offered the greatest potential to increase donation in the province. Again, coming back to that question around deemed consent legislation and how impactful that really is on our numbers. Where we identified our biggest problem was in the realm of identification and referral of patients meeting give clinical triggers. And we know from some of the recently published studies, national studies, looking at donor audits, that that's a common theme across the country and in some places around the world. When we examined just our referral performance between 2017 and 2020, you can see here that there was definitely an increase in referral rates by quarter, but our referral rates by the end of 2020 were 18%. And so definitely showing significant room for improvement. Within our data, the most commonly documented reason for non-referral was an imminent move to comfort care, followed by physician judgment that the patient was medically unsuitable. Another 12% of patients had no reason documented. So those reasons in terms of imminent move to comfort care and physician judgment may be even more common than we were able to measure. In 2020, we identified 110 missed potential donors using the definition of a non-referred patient who didn't meet one of our absolute contraindications for donation in Nova Scotia during that time period. So as an example, patients over the age of 70 years old who were eligible, who would have been non-NDD donors, so DCD donors, we did not recover from those patients during that time, so they would have been excluded from the definition of a potential donor. But I think we've had, certainly in Nova Scotia, we've had a great deal of discussion around how significant this overestimate is. And if we should consider additional relative contraindications that fit into the reasons physicians didn't refer. So, for example, death within 12 hours of withdrawal was an incredibly liberal definition of a missed referral. And since that time, we've tightened it up to a time frame that's more consistent with an acceptable donor warm ischemic time for DCD that would be consistent with our provincial transplanter practice. We also now have specialist donation physicians, and on a quarterly basis, we get a list of the missed potential donors within our jurisdictions, and we review those charts to identify what the issue was in the lack of referral. And what we're actually finding is that when the critical care donation physicians review the charts, we've been able to determine that none of those patients, well, almost none of those patients would have actually been eligible for donation because they were hemodynamically unstable in the hours before their death, which potentially accounted for that high proportion of patients who were not referred because of an imminent move to comfort care. And so we're actually having a lot of discussions now about what our definition should be to give us a more accurate estimate. One of the reasons we stuck to absolute contraindications is those were things that retrospectively were very easy to find in a chart. So the patient was undergoing active cardiopulmonary resuscitation, which was stopped. They had a malignancy in the past 5 years. Those are very easy things for a chart reviewer, a donor coordinator to find documented. But making a judgment call on what is hemodynamically unstable, that's a much more fluid and subjective interpretation. That they sort of felt the donor coordinators and definitely the non-clinical research assistants very much felt that they didn't feel comfortable making that judgment call in the same way as a critical care donation physician would be able to make. And so I think over time, our definition is going to change. Again, limiting that time criteria for give criteria to less than, not 12 hours of 12 hours of ventilation, for example. So hopefully we'll be getting more accurate estimates. And then the second thing is, we're really hoping that the potential donor audit tool is going to become obsolete after all that hard work we did, because all of the patients meeting the give criteria will ideally be referred and captured prospectively in the donor management system, which was used to generate the performance metrics from the past few years, which Alain is going to talk about now.
All right, thank you, Kristina. So having used all of what Kristina presented, like really analyzing and developing a PDA tool. So we were actually able to start our donor management system from those points. So we had a minimal data set we already knew we wanted to capture going forward. And then we had to create a data dictionary. So basically, it was taking all of the papers that Kristina was mentioning and trying to outline what we need to capture for our system. And it came up to approximately 800 data fields. And then we had to incorporate a multiple workflow that will match the organ donation process. And then we wanted this system to kind of connect to different systems. So the transplant database that we have here locally, and also the Canadian Transplant Registry. So from that, so the system is really built to follow all of the organ donation process, as you see at the bottom of the screen. But we wanted to be able to create some organ offers for transplant program, which is usually tedious for the coordinators to do manually, as different depending who you're talking to, they want different information, organ specific. So that was definitely a big win for the coordinators here locally. And we wanted to have all the reporting abilities that Kristina was mentioning. So that being said, it is a web-based application, so it can be actually accessed from anywhere by the coordinators, as now we are moving to a more mobile team and less, I'd say, in the office. So that was important for us. And this is kind of what it looks like. So it kind of helped us manage the increase in volume. So we could create a new referral, or if you have an early consultation about a referral, you could classify this as early consultation, or we have a consultation, but we're waiting on something, and then any active case that we have, and then we have a completed category. So it helps to manage the inflow and all of the referral we're getting, as Kristina mentioned. Once we don't miss any potential organ donation opportunities, then the inflow for the referral will be much, much higher, which we're already seeing now. And this is where we kind of tag along other things we wanted to build that I mentioned earlier. So from that system, so the summary screen is really where we can actually extract all the reports. So whatever we're seeing clinically, I can see how many were consented, how many were referred, and from the referral, how many were actually potential and eligible. So the system will break this down. And this was all built from the PDA work that Kristina was talking about. And also we built a module for our family support. So any family follow-up direct contact is also tagged to that system. And similar, so the chart audit tool that we developed is very similar to our donor management system. So this is where actually, so we get notified of all of the deaths. So we were able to establish automatic death notification around the province within critical care or any unit that would have ventilator capacity. So then this list gets loaded into this system, and then the coordinators or the team here will do audits. And this is how the system will classify. We'll do the exact same thing. How many were potential, how many were eligible, and then we can create our reports from there. So, sorry. Here we go. So same, so from those two together, from both donor management and the PDA tool, is we're able to calculate some performance indicator. We set some donor definition, absolute contraindication, and relative contraindication. as mentioned earlier, we're currently revising this as we're kind of learning as we go, as mandatory referral does bring a lot of, I would say, clinical situation that we didn't have prior to legislation. So that being said, the reporting, I think that was our main goal, and to try to be able to create that feedback loop. So really possibilities are kind of limitless on what we can report. So we combine both system and it can calculate everything we need. So we've been able to report our indicator, like, provincially, if we need by zone of Nova Scotia, we can, and we can go as granular as unit-based metrics, which kind of looks like this. So depending on which hospital we're reporting to, then we can list all of the ICUs or emergency department that we're reporting from. Then it's divided by section. So how many were actually referred, how many that we're reporting that they missed, that they have not referred, and then we give them their referral rate. And then from there, we calculate how many of them were eligible. And then we go all the way to the person becoming an actual donor. So the unit will get how many they've referred, how many they've missed, but also how many of them actually became a organ donor at the end. And that was really important to also give, a kudos to the units, not just report missed donation opportunities. So I would say this gave us a lot of traction around the province. The first year that I've sent the reports, I would say 0 reply, 0 feedback. But now every time I send a quarterly report, I do get flooded with emails, phone calls. People want to meet with us, how they can improve. So it's given us a lot of traction provincially to engage with different quality group, clinical educators. And this is, constantly evolving as we're talking about revising those reports. So some numbers. So the referrals. So historically, before 2017, the number of referral were pretty constant. I would say between 30 and 50 a year. So, and that was like the maximum we were at. And when we look back from all the work that Dr. Krmpotic did, is really realizing our referral rate was actually quite low when we thought we were doing somewhat okay. So when we look back, it's like, okay, there's a lot of room for improvement. So we were able to target what was the need and where do we need to focus. So as I mentioned earlier, 2022, so mid 2022 was when we actually had real engagement, and then you can see the spike of referrals. I think between 2020 and 2021 was really anticipation of legislation that kind of gave us some traction, but then COVID came around and we saw like a dip a little bit because the team was deployed. So, but now we're seeing the spike 2023, and we're already on trend as a trend up for 2024, just looking at the first month and a half. So this is so we're making a lot of effort to approach more families. So even if you get a referral, doesn't mean that the coordinators will actually be able to be in front of the family. So we're making a lot of effort to actually get in front of the family and being able to explain the opportunity for donation. So this has increased significantly since 2022. Again, same as we're able to travel, we're able to engage. So we're approaching more families than before. And our DPM, so sorry, consented. This one is for consented donors. So because of mandatory referral, and now we're getting let's say more referrals and looking at more potential donors, a lot of people that will be given the opportunity to donate after cardiac death has increased. So we do have a lot of attempted donation after cardiac death. Some are not successful and some are. So our consent is higher than our DPM for that reason. But at the end of the day, it does mean that this family was offered the opportunity we gave them the opportunity all the way to the end. So this has gone up. So 2020 was our highest. I think 2020 is a outlier year. And then it kind of went down because of COVID and we're trending back up. So 37 and 23. And then our DPM, as was showed earlier, so 2020 we did get a spike to 34 DPM. But historically, prior to 2017, we were constant between anywhere 15 to 18. So it is increasing. 2021, 2022, again, same as COVID. I think it went down because we did have to stop operation for 3 months of each year. So 2023, we're at 29 DPM. And so far, the projection for 2024, I think we will, I'm not going to put a number, but it's going to be higher if the trend continues. As we saw, we did see a spike only in Q3 and Q4 of 2023. So that being said, I guess is what have we learned? We're still learning, but for me, on the operations side of things, and when we're trying to change a system, it definitely need reasonable implementation timelines. And not to be underestimated, I would be comfortable to say you probably need 2 years to prepare before legislation comes into effect, and to think about everything that you need. It takes a while, and also the hiring of new staff and projection. So it does take a long time. So don't underestimate your implementation timelines. Communication is key. So I did a lot of engagement with internal and external stakeholders, trying to pull in everybody that was a resource that could help. It went from legal, education, communication. So lots of folks can be involved in that process. And sure, so this was probably our biggest lesson learned, because our public education was really overpowered, I would say, by all the COVID media attention, is ensure engagement and co-creation with historically unrepresented communities. So this is our main focus for 2024, to make sure everybody has a voice and is able to bring any concern and have information concerning donation. And as we presented today, is know your data and define your baseline. Is for us, we really took I'm going to say the punitive approach with our data, as our reaction when we first saw a referral rate of 16%, is because we had redefined all our donor definition, what we consider a potential donor. But then we had a lot of improvement after. So define your baseline is really important. We didn't have much resistance in Nova Scotia. We have, I would say, a high support in Nova Scotia historically, and so very, very minimal resistance to presumed consent legislation. Actually, people are usually willing to help when they can. And then, working relationship with your stakeholders, I think that could be within your organization and even outside. It is definitely helpful. For me, I reached out to a lot of other OTOs across the country, and they were very helpful. So sometimes you don't need to reinvent the wheel, just reach out to your peers across the country. So system transformation is slow. So again, having the law is one thing, but changing a culture and transforming a system, I would say, is a different battle. So like Dr. B would say, this is not a sprint, it's a marathon. We're hoping we're going to see improvement over time. As legislation, 1 year after legislation, there was a lot of requests. So people were expecting, like, we're going to see this spike of donation. For me, I was not expecting that with seeing all the system transformation. So it is slow, takes patience, and then you'll have some lesson learned and can tailor as you move along. But the legislation did give us a lot of traction to make the changes we needed, which we didn't have before. So I think that was kind of we're way into a system transformation.
Thanks. So in summary, things that we've really learned. So first of all, deemed consent legislation occurred in the context of a health system reform, and we observed changes in our donation system performance before the legislation was enacted. So this really demonstrates the importance of the health system reform, which I think we can't emphasize enough. Secondly, that the greatest potential to increase donations, certainly in Nova Scotia, has been around our identification and referral. We had high consent rates. And so again, the legislative change, the questions about deemed consent, which is the one we're most commonly asked about, was that really necessary, and was it where to get the best bang for our buck, when really it was a lot of the education around the province and the other infrastructure changes that have made a difference. And then, Alain, if you could, yep. And so lastly, the fact that we've already started to see significant improvements in our system performance, and that we are very optimistic for the future, that over the next few years, we're going to continue to see the rise in our performance.
Thank you very much, Alain and Dr. Krmpotic. This was an incredible presentation. And I know there must be quite a few questions about this. You're obviously building a very robust system in Nova Scotia. And thank you so much for sharing the development. And we're looking forward to the future changes as well. So I'd like to put it out now to the attendees. We've got a great attendance for questions. There is one in the chat. Is the donor management system for tissue donor referrals as well, or just organ donor referrals? And if not, are there plans to expand it to capture both?
So
Great question.
Yeah,
So,
no, go ahead.
yes, I'll go. I've been working through that. So the donor management system was really focused on organ specific at the beginning. So right now we're at phase 1 of looking for tissue, but which is really just for the front end of tissue. So managing referrals, so kind of the same principle. I don't think we will be able to apply it for, storage of tissue, distribution of tissue. That will need to be a different solution, which could be similar. At least we have a canvas for tissue, and that's the plan. Is some of it will be able to be used for tissue, and they just implemented phase 1 of being able to manage referral intake for tissue, which is much higher than organs. And the phase 2 is to look how can it apply all the way to tissue recovery. So there could be an application for that, and the canvas will be built, but we don't know yet about the storage and distribution of tissue just yet.
And just to elaborate on that a little bit, one of the things that's different in Nova Scotia than many other places like Trillium in Ontario is that we're separate organizations for organs and tissues. So Legacy of Life is, although we're sort of affiliated and work together, and Legacy of Life, is organ and tissue donation. The regional tissue bank is a separate referral process. And so one of the things that we found when we were developing the potential donor audit tool and going in our chart audits was that we actually had to stop collecting information on tissue referrals and tissue donation because we couldn't reliably extract that information from the chart, particularly for cases who did not go on to become consented organ donors. And that would be one of the things that I would say a lesson learned for when we were developing our system is that collaboration going forward with organizations like the Medical Examiner's Office and the Regional Tissue Bank to have accurate systems of tracking. Those were things that on retrospective donor audits, we couldn't capture that information.
Thank you. I have a question from Laurie West, Dr. West. Laurie, would you like to ask the question? Okay, I'll go ahead and ask it. Thanks for this very informative presentation. Any specific suggestions for Alberta?
That is a loaded question for sure. I guess is what I've learned with time is, and I realized that every province function actually very differently and have a different system. and even the different hospital setting systems. So it's some of our information is you could probably translate to Alberta on, okay, we need to define our baseline, we need to have some components of it. I don't know if everything could apply because the system is so different. But I think if legislation is around the corner, your first step is, what are you expecting with this legislation? What is it going to cause, operationally? Can you support it? Because I mean, the focus of legislation is around providing the option to the families that are in a position at the end of life with their loved ones. So that's kind of what you want to do. But can your system support it? But what do you need to actually monitor that? I think that's a good place to start from my perspective. And from there, you can actually build upon. But the suggestion could be very specific to Alberta.
Thank you.
I would say from my perspective, very bluntly, I think what we're going to see over the next few years is that the deemed consent legislation itself isn't the answer, and it's not where we're all going to see that's made an impact. I think truly, I believe that it's all of the things that went along with it, and all of the the investment, the frontline financial resources, the change in the organizational structure, the ability to support regional hospitals. I actually think probably where we're going to see a difference is looking at parts of the donation process where we can target the most effective areas. And I think that would be not just specific to Alberta, but across the board, is that I think we have to be very mindful about the legislation itself. And just to give sort of a related example, if you look at some of the studies that were done in the 2015, 2016, in comparison to ours. So you look at provinces like Ontario that have 99% referral rates, and you look at provinces like ours a couple of years ago with an 18% referral rate. Well, identifying a similar number of missed potential donors, if you have an untimely referral, that's no different than having a missed referral. And the questions around, well, what are the estimates correct? And where do you target? So examining intensive care units and emergency departments, is it worth it to really target a specific area? Or, is it worth it to target academic centers versus non-academic centers? Where truly is our loss? And I think focusing on consent and whether people are opting in or opting out is probably a very narrow view of our potential to increase deceased donation.
It's interesting. Thank you very much. I'm sorry, I was overly muted and searching for my button, but that's kind of what we read about, from Spain as well. When they first, started publishing the change in their system years ago, it wasn't any one thing, and it certainly wasn't the presumed consent legislation. It was all the things together that you identify as potentially contributing. I guess it really speaks to the need to evaluate, though, the impact of any changes that are undertaken, like you've done here in this really spectacular evaluation of what you've done in Nova Scotia.
Yeah, I agree, Laurie. If you look at the literature, there's a couple papers published. They're just very short commentaries on when the legislation was passed in Brazil, and they redacted the legislation a year later. And people actually, donation rates went down because people didn't trust the government because it was only about the legislation. So again, a prime example of how it doesn't work if you don't support the whole reform of the health system.
And the impact of undertaking an evaluation of that, I guess, the really vital importance of evaluating the impact of changes.
The fact that you evaluated as you went and made adjustments as you developed the system is kudos to the system for doing that. Any other questions from the audience? I can ask one. Patient engagement. We see that the family support system was further along the chain of activities, and we've been having conversations in the global different organizations about where to engage support to the family. Obviously, ICU or emerge, but what does that support look like? And have you been able to incorporate family input to identify where that support is required through pre, during, and post, and not just immediately post, but later?
So, great question, Linda. So that is probably the first thing that I focused on with family support is exactly of what you mentioned, pre-donation, what we need, during donation, what we need, and post-donation. And this is kind of where we started, because I'm not going to say this was non-existent before, like the ICU team would support during, but we didn't have anyone focused while in that process. So this is where we got a lot of feedback from families. So we do ask them to provide feedback and able to tailor that and increase supports um, where it is actually needed. And we even changed our strategy when some publication came around to say you need to focus on critical transition. For example, when their loved one is going to organ recovery, and the family is kind of left in the ICU. So we're really trying to focus the family support in those areas as well. The pre-donation support, I would say, is a little bit more challenging depending on your system. So if the family is in another, let's say, area of the province, is how do you provide them support if, let's say we're based in Halifax and they are, at the other, on the other end of the province. So we're trying to establish some virtual support at minimum, support the ICU, provide any type of resource a family would need pre. But I think during the process and the post donation, I think is probably easier. I think pre-donation is a little bit more challenging, and we're focusing on that. So we asked every family to fill a survey, get some feedback. Um, Family representation on committees to get feedback and read our materials. So we've been trying to engage the families more.
I think the the other aspect of that and speaking from a bit of a researcher lens, is answering those questions again about that missed potential. So as an example, here in Nova Scotia, we only recover in Halifax. And so a patient who is a potential donor who is in a regional hospital, the family not only has to consent to donation, but they actually have to consent to the patient being transferred to Halifax, which, as you can imagine, for a patient who is a potential DCD donor, who may not die in the allowable time frame, who is not already deceased, family members want to come, it's quite a burden and a consideration. And we don't actually know if that's one of the reasons why families don't consent. We don't know if it's a reason why why healthcare providers don't refer, is because they assume the family wouldn't want to. And so I think that point about the family perspectives, I also think having patient partners to define what those research questions need to be, obviously becoming more common. And on the LEADER Consortium, we did have a transplant recipient as a patient partner, but we didn't have someone from the organ donation side to say, my loved one was an organ donor, or my loved one, didn't become, or I didn't consent, and here's why. So I do think there's a lot of room for growth in that area as well.
Thank you. Could one of you comment on the key communication strategies that you focused on, the ones that you felt were most effective in disseminating information and education?
So the first focus we had was really healthcare provider focus. We had, some, I would say, media blitz about presumed consent, but really it kind of overpowered everything. Everybody was focusing on presumed consent when I think it overpowered the ideal of organ donation and donation overall. So we refocus on, let's say, the healthcare community. And one is, what do they need to know? Because if you talk to someone, the majority will say, will support the ideal of organ donation. So it rarely met someone that says, oh no, I don't support organ donation. But when you actually get down to, you're in a situation where you could potentially be an organ donor, there's some consideration. For example, transferring, recovery timelines. So we really engage with the healthcare community to try to have focused conversation about all of these things. Before going to the table, we did come with numbers. So our reporting system was really helpful with that because people will want to see, well, are we talking about one person that we've missed or are we talking about 15 or 20? So one of the strategies is define your baseline and know your data and come to the table with that. It will make more productive conversation when you're engaging with different folks. Also, know who you're speaking to. So for me, I know the needs for different sites are different. So if I engage with, one hospital, I know what their challenge is. So I come to the table with that information for them. So it's very getting to know who you're engaging with as well.
Thank you. Was there a significant focus on the economic impact of the transformation, in addition to obviously the primary, which is system transformation to improve care?
So the leader was a massive collaboration. And when I was introduced, we talked about activity one, which was the quantitative aspect. There were actually 3 activities. The first was the quantitative evaluation. The second was understanding the international experiences. And then the third was sort of a more qualitative evaluation. And under the quantitative, we did have some economic analyses. Those to date have mainly been focused on what is our potential. So if we grow our potential and as we grow our potential, what are the impacts of those going to be on specifically kidney transplantation rates? And, what is the economic impact of that? I think there are plans to look at the overall economic impact. Certainly a very relevant question about the amount of money that's been pumped into the system to make all of these changes. And I think, a plan to evaluate exactly that. But I think that's, again, part of asking the question about where do you direct those resources? Our resources are limited. Do you direct them at improving your consent rates? Do you direct them in the emergency department if you're missing one missed potential donor every couple of years realistically? So yeah, I think we don't know. We haven't done an analysis, but an important thing.
Okay, thank you. We have one final question before we close from Dr. Kramer. Andreas, would you like to ask the question?
Sure. Yeah. Hi. Thanks for the presentation. We know that that deemed consent or presumed consent is really a soft presumed consent and not a hard one, meaning that there's still going to be a conversation with substitute decision makers / families. And so my question is, practically speaking, having had deemed consent legislation for 3 years, I think now, I'm just wondering what practical impact that has had on the nature of the conversations that occur, and the wording maybe that's used, and whether it's changed at all.
So
thanks.
Great question. We get that question all the time, actually. So it did change the way we approach a conversation. So that was step number 1, but it was also a learning curve because normally we would approach the family to obtain consent. So for the team, they had to get used to say, okay, if this person has registered, they want to be an organ donor, we're approaching this as advocates to their last expressed wishes. So our approach to the family has changed. So we have to develop all those kind of strategic approach and scripts on, how do you approach a deemed consent to a family that would be very different if you approach someone that had registered they wanted to be a donor. So it changed the conversation at the family level at minimum. So a lot of family I would say just this year, a lot of families that we actually approached had the conversation about donation, which we've never seen historically, because I think the legislation itself, or presumed consent, get people to talk about this. Now they're actually, when they review their medical health card in the province, they're asked, do you want to be a donor? If you don't register anything, deemed consent applies, if you're not excluded. So the conversation has changed a lot with families. So is the question of did deemed consent change anything? I'm probably on the same wavelength as Dr. Krmpotic. I'm not too convinced, but it did change the approach with families. So I feel we see a lot more family willing to or wanting to respect their loved ones' last expressed wishes. And for deemed consent, a lot of people don't register their decision in Nova Scotia because they say, well, we have presumed consent, I don't need to register. But they actually had a lot of conversation with their family. So we're seeing that way more than before. I would say almost more than half of our family have had a discussion. So when we approach them to affirm either their decision that is registered or presumed consent, they actually know what their loved one wanted. So the approach is very, I want to say easier.
Thank you. Well, we've reached the end of our time. Tremendous presentation. Good questions from everyone. And thank you again to all for attending. Thank you again to our sponsors, Plaid and Astellas and AstraZeneca.